Hi everyone, my name's Sashika. I'm one of the final years on MUPPITS this year, and I will be delivering the revision lecture on genetics, infectious diseases, and dermatology. Um, so I'll start off talking about infectious diseases and specifically viruses that are caused by rashes. And so these are the main ones that I'll be talking to you guys about. So measles is a viral infection that causes a rash throughout the body. It's usually a rash that is a blanching um, red maculopapular rash. And it is preceded by these spots on the buccal mucosa opposite the teeth called Koplik spots. And once the rash itself is over, it essentially peels off. It's a continuous rash throughout the body, usually starts behind the ears and spreads downwards down the trunk. It's important to note that the incubation for measles is about 1 to 2 weeks, and then people are infectious from a couple of days before the onset of symptoms, and then for about 4 days after the onset of the rash. So there is a prodrome of symptoms, including the Koplik spots. Management is largely symptomatic. So manage the fever, the aches and pains, make sure they're well hydrated, make sure the patient's well rested. There is a requirement for school isolation for at least 5 days, and the Department of Health needs to be notified within 5 days. The main problem with measles and the reason we have things like the MMR vaccine is because of concerns about subacute sclerosing panencephalitis. So subacute sclerosing panencephalitis can cause demyelination, which ultimately can lead to death. And measles itself can cause things like otitis media and pneumonia, but those can be managed relatively well. But our primary concern is this panencephalitis, which is why we have preventative measures. So rubella is quite similar to measles in the sense that it's a rash that starts behind the ears and spreads downwards. However, it's not continuous and it does not desquamate or peel. It has a similar transmission in the sense that there's droplet transmission, incubation period's a bit longer, but there's still the prodrome, just no Koplik spots. And the infectious period is also a little bit longer. Management is very, very similar, pretty much the same. And congenital rubella is hopefully something that they will talk to you about in your obstetrics and gynecology lectures. But something to be aware of and a part of screening because of the complications of congenital rubella. So varicella zoster virus is essentially a vesicular rash that forms. First, it'll start off like small red bumps, then they'll become the vesicles. Then those vesicles rupture. Eventually, they crust over, and then the rash will, disappear. It's a very itchy rash, which is why we use things like calamine lotion specifically on the spots themselves to reduce that itching and reduce the pain associated with the rash. The rash is no longer infectious once the vesicles crust over, and that should happen within, by about day 10. That's when the infectious period stops and the child can ultimately go back to school. We do have antivirals available, but we really only need them for neonates and individuals who are immunocompromised. Otherwise, like the other 2 rashes I've talked about so far, this is another viral infection where it's largely just symptom management. So these are the other virus-induced rashes that we need to be aware of. So slap cheek, caused by parvovirus B19. Usually, like 3 kids, like siblings, will come in together, and they've just got like these really red cheeks. Now, the onset of the rash is happens once the child's no longer infectious, so they don't need any school isolation. And there's not many other symptoms other than the slap cheek itself. Um, and so, you know, there's no need for school isolation. Um, Roseola infantum is characterized by a period of fever, then the fever stops, and then there's an onset of a rash on the trunk. It's caused by human herpes virus 6. Hand, foot, and mouth disease, pretty self-explanatory, happens in those areas. Usually, it's in younger children because putting things in their mouth and touching the environment around them is a big part of how they learn from the environment around them, especially when they're younger. And so when they have these little blisters on their hands, their feet, their mouth, and those blisters burst, it's very easy for that to spread in younger kids. Molluscum infectiosum is essentially like these round, centrally umbilicated bumps, and they can happen pretty much anywhere in the body. They last for a really long time, so the rash itself you stick around for like a year, but other than the rash, there's no real systemic symptoms, so it doesn't really bother the patient very much. But it's important to note that it is really infectious, and so the fact that it's really infectious and also lasts for a long time can cause problems in itself. And then herpes stomatitis is just HSV in the mouth. This will often present in younger children who aren't able to verbalize yet, and they'll just, be brought into ED or the GP because they're not eating and drinking very much, and you have a look in the mouth and they've got vesicles everywhere. Cool. These are pictures of each of those. So non-viral skin infections. So non-viral skin infections are essentially, we're mainly talking about bacterial infections. So impetigo caused by Staph aureus, they'll describe it as having, very much this honey crust appearance. It's caused by usually, when people get cracked lips and things, and a Staph aureus infections gets in there and then causes impetigo. It's important to not touch those crusts or the area that's infected because it's highly contagious. There is a need for school isolation and just a bit of avoiding contact with other members of the family if possible, due to the fact that it's very, very contagious. There is topical antiseptics that we can use for the lesions itself, and then if we've got a more systemic infection, we can use some stuff like flucloxacillin. And the problem with impetigo is we want to be aware and keep an eye out for signs of things like bacteremia, because that can develop and it can become a systemic infection. Cool. So scarlet fever is caused by group A strep. It's like a sandpapery rash that develops across the trunk, and then also often like sunburnt appearance that's more on the face, with a perioral sparing or pallor. They'll also get a strawberry tongue similar to Kawasaki disease, but scarlet fever you won't see it so much in younger kids. You'll see it in slightly older kids. And then treatment is phenoxymethylpenicillin for 10 days, school isolation, also just because the kid will feel quite unwell, and then a symptomatic treatment as well. Cool. So scabies is essentially just mites burrowing under the skin. It's not great. It essentially, the female mite burrows under the skin, hatches eggs. It's the eggs then release antigens, which creates an immune response and a hypersensitivity reaction, which causes the itching. Um, uh, for treatment, it's permethrin cream, and then you also treat the entire family as a preventative measure. So Kawasaki disease is a vasculitis caused by a range of different things. So we don't have like a specific reason why children develop Kawasaki disease. Sometimes parents will come in and saying, oh, they were sick for a little bit before and then they got better and then they got sick again. So there's a range of reasons why they could get the illness, and we don't have a known etiology at the moment. In terms of diagnostic criteria or even just symptoms, it is a clinical diagnosis, and the way to remember the diagnostic criteria is warm cream. So warm as in fever of greater than 38.945 or more days. And then cream for conjunctivitis, bilateral conjunctivitis, R for rash. It'll be similar to the rash for scarlet fever in the sense that it's on the trunk, but there's no sandpaper like quality to it. There will be extremity changes, so like edema of the hands and feet. It'll be like quite red hands and feet as well. And then unilateral cervical adenopathy, and the lymph nodes needs to be greater than 1.5 centimeters in diameter, and then end for mouth. So oropharyngeal changes, things like strawberry tongue, they'll have really cracked lips sometimes. And then they might have a pharyngitis as well, but the main two to remember are like the strawberry tongue and the swollen cracked lips. Cool. So management-wise, we give high-dose IVIG plus aspirin. So essentially, the thing that we're worried about is coronary artery dilation or coronary artery aneurysms. Now, when we give aspirin, we need to be aware of Reyes syndrome, which is an acute encephalopathy and hepatic steatosis that can develop. But ultimately, our primary concern is identifying Kawasaki disease early enough so that we can avoid the development of the coronary artery dilation or aneurysms. Cool. So atopic eczema, you would have talked about this last year in GP and now also in peds. It's just usually in a triad, or more commonly in a triad. Kids can get eczema by itself as well. In smaller kids, it'll be mainly on the extensor surfaces and on their face, whereas as we get older, it's more likely to be on the flexor surfaces. So in terms of management, step 1 is emollients, so essentially moisturizers. Step 2 is topical steroids, but just on the areas where the eczema is. And then you can increase the dose of that as if it's not working. Step 3, you can introduce things like wet wraps and phototherapy. And then step 4, consider the need for systemic steroids. But at that point, you probably go beyond GP management. Alrighty. Oh, obviously, things like avoiding irritants, avoiding perfumes, making sure then they're like sheets and things, avoiding things that can make them that can irritate the skin more, in terms of some materials in sheets and pillows and so on can irritate the skin more. Antihistamines, if to avoid itching and breaking the skin, which can make everything significantly worse. And then seborrheic dermatitis, or cradle cap in babies, is essentially just a yellow crusting that forms due to inflammation in the sebaceous glands. There is some sort of microbial or infectious involvement, but etiology isn't entirely understood. Management-wise, you can, in babies, for cradle cap, you can often loosen the little plaques off. And you can use things like anti-dandruff shampoos as well. And it usually it just will self-resolve. Cool. Moving on to genetic conditions. So Down syndrome or trisomy 21, it can be screened for during antenatal screening, and we can also do it postnatally, but that's more diagnostic rather than screening. So Down syndrome has typical features that we can identify at birth. So things like the hypotonia is evident almost straight away at birth. Once the baby becomes slightly older, like a day or two old, the facial features become really prominent. So the flat facial profile, broad nasal bridge, the epicanthal folds, and then particularly the small mouth become a lot more prominent on day 1 or 2. Down syndrome can be associated with intellectual disabilities, the onset of Alzheimer's. So that's an important link to remember, the link between Down syndrome and Alzheimer's. That usually presents in almost all patients by the time they're 20 years old. Hearing impairment, vision impairment, and particularly AVSD in terms of congenital heart defects, and also GI malformations. I think the main associated conditions I would remember are Alzheimer's plus or minus intellectual disability, plus the congenital heart diseases, particularly AVSD, and also the GI malformations / Hirschsprungs, I think would be the main ones I'd make sure I remembered. And then neural tube defects. So there are a variety of severity in terms of neural tube defects, but they all occur due to folate deficiency during pregnancy, or they can be inherent fetal causes that are not related to the availability of folate. So spina bifida occulta is the least severe form, and therefore also just happens to be the most common form. It's where the vertebral bone itself does not fuse, and so there is no herniation of neural tissue. And then meningocele is where the meninges and also the vertebral body do not fuse, so the meninges herniate, but again, no neural tissue is affected. Myelomeningocele or meningomyelocele is where there is some neural tissue that herniates, and so the neurological symptoms that result from that is dependent on how much neural tissue herniates. And then the last one that I can't say is where a much larger portion of neural tissue herniates, and therefore the neurological symptoms are much greater. In terms of management, high alpha fetoprotein in pregnancy can be used as a tool for detecting potential neural tube defects, and therefore being prepared for that when baby's born. Ultimately, management is surgical. So these are the different types of neural tube defects. All right, so fetal alcohol syndrome essentially results from alcohol consumption during pregnancy. There is no safe amount of alcohol during pregnancy. Um, you know, people talk about like safe amounts of coffee and things like that. Does not apply at all to alcohol. Um, so there are specific facial features, and they end up being quite similar to those seen in Down syndrome, but there's less prominent facial features in fetal alcohol syndrome. So the epicanthal folds, the thin upper lip, and the mouth itself also just ends up being smaller. And then the flat nasal bridge is also a common feature. It's associated with growth deficiencies, cardiac abnormalities. It can relate to intellectual disabilities and overall poor executive functioning in abnormal brain structure and imaging. So for a lot of babies with suspected fetal alcohol syndrome, they often need an MRI brain to assess the structure of their brain. That's often involved in the process of diagnosis. So plagioccephaly and hydrocephalus. So plagioccephaly just means flat head. It's not really a big issue. It can, often be reshaped because babies' heads are very malleable, and it just happens because they've been sleeping in one position for a long time. So it's more likely to happen in babies that have been in hospital for a longer period of time. And then, there isn't someone always, it's very busy, and sometimes staff don't always have enough time to turn baby over and give tummy time and things like that. So it's very easily fixable. Hydrocephalus, more of an issue because it's related to increased CSF in the brain, and that might be due to too much CSF being produced, it not draining properly. It can be due to uh, um, issues with masses within the cranium, which is causing raised ICP and so on. But because baby's skull is so malleable, it kind of expands and they just look like they've got a huge head. Management is ultimately surgical, and they can insert a shunt to drain that CSF. Cool. So there are lots of other congenital conditions, and unfortunately, you just have to remember the buzzwords for them. This page and this next page I'm about to show you have all the ones that I think are important to learn the buzzwords for. And I've highlighted the buzzwords in red. For Turner syndrome, just learn all the buzzwords, which is why I've just put Turner syndrome in red. So yeah, sorry about that. I'm not going to go through each one individually because it's just a matter of memorizing essentially. Cool. Last thing is the national immunization schedule. So you'll do this, this is relevant to both GP and to peds. So the national immunization schedule is a preventative measure used in most countries. This is the schedule for Australia. And there's a bunch of different vaccinations that you need to remember, but I found last year that this kind of guide helped me remember things better, in the sense of like 1 at birth, 3 at 2 months, 3 at 4 months, 1 at 6 months, 3, 3, 1. So it's just like 1, 3, 3, 1, 3, 3, 1. Birth, it's the Hep B plus, remember vitamin K at birth as well. And then 2 months, Infantrix Hexa, and so on, right? So just like remember that there are 3 for each of 2 and 4 months. They're similar for 2 and 4 months, and then slightly different for 6 months. And yeah, again, just a bit of memorizing. Cool. So I think that's all I have for you guys. My email is is here. Feel free to send through an email or send me a message or anything like that if you have any questions, and I'm happy to help. But yeah, good luck, and um, hope you guys have as easy a PEDS exam as we did.